So, hi, I'm Sarah Klein. I'm a physical therapist on the chronic pain team. And one of my passions is talking about how to explain pain to families and teens. I have no disclosures or commercial interests. And what I'm hoping that we can all learn together today is just the importance of pain education and pain neuroscience as part of pain treatment. Hopefully, a little bit more language on how to explain persistent or chronic pain to adolescents and their families, a little bit of an overview of some management strategies that encompass our 3P or a multi-pronged approach to treating teens with chronic pain, and also the use and hopefully support the use of some language to reframe pain in the context of a 3P approach to pain management. So let's jump in. We know that by the time teens, families, patients make their way to a chronic pain clinic in order to receive their pain diagnosis, they may be very frustrated. They may be very confused. They might feel very dismissed or misunderstood by the healthcare community. They may have been through months or years of investigations with no clear answers or reasons for their pain. They might have something called diagnostic uncertainty, where they're unsure what or where the pain is coming from. And they might feel that something's been missed. They might have heard that the message that their pain isn't real, or that it's in their head, or that it's all psychological. And therefore, they might be hesitant to engage in any type of treatment because they don't really understand their diagnosis or the treatments that are indicated. They might have tried some of the treatments already and felt that they were unsuccessful, like typical movement with physio or mind-body strategies might have felt that they failed and that there was no good effect on their pain, and that might result in a sense of hopelessness. Furthermore, a lot of the treatments that we do offer for chronic pain focus on improving function, as we'll discuss, despite the pain being present, with the use of physical and psychological strategies. So it might seem counterintuitive given that we are raised to learn that pain is a sign of ongoing damage and it's something we should protect ourselves against. So we know that in terms of treatment, there's a lot of compelling evidence that an educational strategy that addresses the neurobiology and neurophysiology of pain can actually have a positive effect on pain catastrophization. It can help decrease disability that is pain related and also help improve physical performance. If we can reconceptualize what pain is or help support the reconceptualizing of what pain is, we can help improve physical performance. And using metaphors and other educational materials to help explain what pain is can actually help support a patient, a teen, to engage in a multimodal approach to functional rehabilitation. So we know that if we can understand what pain is, we can help support that actually as part of the treatment for pain and to help our teens and kiddos regain their function. It is true that a lot of the evidence is more in the adult world, but we know that even in the kid and teen world, utilizing an educational strategy can help make them ready to engage in our multimodal approach. We know that we should be using words that are helpful. We should know that we should be minimizing any type of jargon that connotes more danger or increases a person's concern about what their pain is. So using words like motion is lotion, movement is medicine is very helpful, whereas saying things like degenerative disc disease or a break that's worse that you've ever seen, that might actually create more pain as that increases person's danger in their brain. At the end of this, there's some resources, and there's an article that talks about a state of education and pain neuroscience education in the pediatric world. And we know that language is important when it comes to teens, but also their families. So for example, there was something called a cold pressor test where they used a stimulus that was a cold pressor on a child's finger. Anyone who was set up for the test with threatening language describing what the test was actually had higher pain scores and higher pain catastrophization scores about what the test was compared to the other group, and as well as their families had higher pain scores or perceived pain scores for their children. So we know that language is important in describing things and can actually change the brain's perception of what's going on. So let's jump in to a little bit of the basics of neuroscience of pain. And really what we're trying to do is, even though we're going to talk about a lot about the brain and body, really try to get away from this idea that pain is all in our head and pain is always a sign of ongoing damage. Traditional beliefs are about pain. Even when I went to physio school back in 2004, pain was always a sign of damage. Pain was always a sign of dysfunction, irritated tissue, injured tissue, unhealed tissue. And we're shifting that belief. So what do I mean by that? This was a pain definition that's now been revamped. But historically, we thought that when someone had pain, it was a sign of injury. So I walk, I step on a nail, that causes injury, and I get a pain sensation. And maybe I have a cognitive or behavioral response, like I cry. But we also know now that it's much more complex than that, that you can get a pain message not related to injury, and that sometimes the cognition actually can impact your pain perception. We know it's a lot lot more complex and multidimensional. It's not just a biomedical model where pain equals injury. And this is the IASP definition that was revised in 2021 that added a lot of clarifying points to capture what the definition of pain is, which includes a person's past experiences, an expression and subjective report and expression of pain that's beyond verbal communication. So what does it look like when we get some sort of painful stimulus? What is actually happening in the brain and body? So in transduction, so let's say the idea of stepping on a nail, that's some sort of nociceptors or receptors in the periphery, like on the foot where you step on the nail, are activated by some sort of noxious stimulus, which could be mechanical, chemical, or thermal. So for example, stepping on the nail becomes the noxious stimulus. In transmission, these impulses travel along the peripheral fibers to the dorsal horn of the spinal cord, and then they're relayed to multiple areas of the brain. So for example, the somatosensory cortex, the insula, the frontal lobe, the limbic system, multiple areas of the brain are involved when there is some sort of stimulus that comes up. In perception, the somatosensory cortex and the insular cortex allow the person to identify the type and intensity and body location of where that noxious event happened. And then the limbic system will mediate the emotional response. So just like I said, you stepped on the nail, those messages went up, the brain decided where that was happening, what exactly was happening, and then the limbic system might create that behavioral response or emotional response, like you get upset or you cry or something happens because of that. But we know that there's this descending modulation, and modulation can occur in different ways. And really, I explain it, as you'll see in a little bit, of turning up the volume or down the volume on these messages. We can have inhibition of this nociception. So these pain messages or danger messages that are sent down to tell us that something's going on in our periphery, they can decrease through the release of neurotransmitters like serotonin and norepinephrine. But we can also have facilitation or increasing in these nociceptive messages and consequently more pain. Some of the contributing factors that drive this facilitation might be fear, anxiety, worry, or past experiences. I'm not sure exactly how all that works, but we do know that it's a true phenomenon. So for example, if someone were to roll their ankle and have an ankle break, that would send all those messages. The brain would determine that something dangerous was going on, and then it would send a danger message back down in the form of pain to know that you've got some sort of injury. But if you got that same mechanism of injury and rolled your ankle as you were trying to cross University Avenue and there was a bus oncoming, you would likely not get those danger messages, because at that time, the brain would decide that it's more important for you to get to safety than it is for the brain to stop you with all those pain messages in the middle of the road. And so we know that there's ways that the brain is involved in controlling the volume of the danger messages that are sent down. So changes with persistent pain, because even though this is how the brain works and the body works when it comes to messaging related to acute injury or important injury, as we traditionally feel that pain is always related to, we know that with time, there are changes that happen that keep the cycle going after the tissues have healed, after the injury is gone. We know that the nerves in the periphery might fire more easily or more frequently. We know that there's a misinterpretation of that messages when it comes up to the brain. We know that the brain is kind of in danger or protective mode and detecting all the information from that part of the body with more vigilance or concentration. It's more likely to be in danger mode and therefore more likely to send down danger messages in the form of pain. And there's some evidence to say also that almost like the map of that part of the body in the brain is altered to a certain extent. There's lots of different things that can create the brain to be more in protection mode, and that would be that facilitation of the danger messages. And that's what kind of happens, and this cycle kind of persists when pain is ongoing for a long time. So all that was a bit technical and a high level. And so how do we now kind of change that in order to share that with our teens and our families who are trying to understand their pain and how to manage and treat it? So here's where we start off. One of the most important and foundational things that we have to understand is that all of our conscious experience happens in our brain. So what we're tasting, feeling, seeing, touching, hearing, all that is brought by nerves or circuits or wires up to the brain for processing. And a very non-threatening high-level example might be that, if you walk outside today, it's windy, it's snowy where I am. If you walk outside on a winter day and a gust of wind or a snowflake touches your hand, that information travels through the nerves to the spinal cord and to the brain. And the brain does that complex evaluation, similar to when it had that noxious stimulus where it says, I live in Canada, it's the month of December, and I sense some sort of change in temperature at the location of the hand. And based on that, the brain would actually process that you're cold and maybe send a message back down. So for example, a reflex might be that you would shiver because movement causes warmth, or it might also shift your behavior and you might go put something warmer. So that's a very high level or non-threatening example of how the brain and body work when understanding things in your environment. And actually it works similarly when it comes to pain. A classic example that I might share with the teens and kids is that let's say I'm hammering something, I'm building something, and I'm hammering, and accidentally I hit my finger. At that time, that noxious stimulus happens, would activate some of the nerves. And so those nerves would send the messages to the spinal cord, to the brain, and the brain would say, uh-oh, there's some sort of danger there. There's some sort of injury. And the brain actually sends a danger message in the form of pain so that I know that I need to stop what I'm doing. I need to protect it. That's a helpful message. It tells me that I should stop hammering, that I should go wash it off. I put some antibiotic cream, maybe some ice, a Band-Aid, whatever it is. That's a helpful message because it tells me that there's some sort of injury there. And this is when our pain system works well. This is when pain is a protective response. It's helpful. And I ask the teens and kids, have you ever gone too close to a campfire or stove or a candle? Inevitably, one of them will say yes, hopefully not, but might say yes. And I say, at that time, what might you feel on your hand as you're getting a little bit close? They say a burning sensation, discomfort. And what is that meant to do? It's meant to be a message to pull your hand away. So when that information travels up to your brain is actually sending a danger message in the form of pain in order to get you to pull it away, in order to maybe protect you from even potentially getting injured. Hopefully you got that message and you were able to pull your hand even from before it got burned. This is another example that I usually thread through our session of Johnny, who was a teen that came to our clinic. And one of the first experiences with pain that he had was when he was going for a layup in a championship game in basketball, and he landed funny on his ankle in grade 9. And he actually had an ankle break. And so at that time, information from the ankle break traveled via those nerves to the spinal cord to the brain. And the brain detected that there was an injury and sent down a danger message in the form of pain so that Johnny knew that he had to stop running around, get off the court, call an ambulance, get to the hospital, get an x-ray, and get in a cast so that he could protect it so that it was healed. That's when the pain system works well. It tells us about getting tissue damage or actual tissue damage. We know that it's when the pain system works well, that it tells us when there's something important that's going on, but we have this idea of modulation of pain, and that means that the brain can turn up the volume or turn down the volume on those danger messages. So an example I might ask is, you're getting ready for bed at night, have you ever noticed a bruise on your leg and you're not sure where it came from? And inevitably the teens and parents might say, yeah, that's happened to me before. And I say, well, that's an example of an injury, some sort of non-important but injury to the tissues. Why do you think you didn't get that danger message? And sometimes they say maybe it's not considered super dangerous. And it's true, right? If you've gotten lots of bruises when you were learning to walk or were playing at the park as a kid, then it might have deemed that the brain, when those danger messages come up, the brain is kind of like, yeah, this isn't super important. This isn't important enough to stop what we're doing. And so much kind of just quiet those messages, right? So there's that volume down on those danger messages. Even though the injury is there, the brain is kind of not considering it super important. And if something's not deemed it dangerous, it's not going to get those danger messages down. Another example might be a paper cut. So paper cuts tend to be super annoying, and usually they come with a little bit of blood. And one of the reasons why people's pain experiences is high, because I ask the teens and kids, have you ever noticed when you get a paper cut, it's kind of jarring when you see the blood and you get that pain experience or that pain message related to the paper cut, even though it's not a super important cut? And they say, yeah. And one of the reasons is because blood is a sign of danger. So when the brain is deciding, is this something important or is this not? Visualization of blood will actually tip that danger message to go forward with higher volume. And so the brain might be more likely to send down those danger messages. But I also say, like, let's say with the paper cut, so you get that danger message, maybe it's related to pain, maybe it's related to the injury that's just there, and you clean it up, you take care of it, you wash it, you put some antibiotic cream, maybe you put some Band-Aid, whatever it is, some ice. The next day, so you have your cut and you are getting that danger message from your brain so that you can go and take care of it. So you wash it, you put some cream, you put a Band-Aid, some ice, whatever it is to help manage it. And the next day, is the cut still there? Oh yeah, it's still there. But are you getting those danger messages as much? And the answer is no. And one of those reasons is because the brain is satisfied that you've taken care of it. So even though the injury is still there, the pain messages are not as high. Again, that there's not a one-to-one relationship between danger messages of pain and injury, illustrating that sometimes you can have injury and no pain, and sometimes you can have pain but no injury that's present. And this is an example of an athlete that was playing a championship game and played the whole game with a torn tendon sheath. So for whatever reason, the distraction of the game was keeping him completely unaware of an important injury. So again, the power of the brain is really high. Sometimes we even would like it to attend to certain things that are actually dangerous. Pain is not our only protective system. We also have another protective system that's highly related, and that's called our fight, flight, or freeze system. system. And I asked the teens and kids, have they ever heard of the sympathetic nervous system or the fight, flight, or freeze system? And some have and some haven't. But we like to take a look at it and see how it relates to pain. So I say to the teens and kids, what would happen if you left this session and a lion jumped out at you? What might happen? And they say, oh, we might be scared or fearful, excited. One kid once said they would be curious, which is also a good emotion. But for the most part, people would be scared and worried. And I say, well, okay, that's the emotion, but what might you feel in your body looking at this and looking at all the different systems? What might you feel in your body? And they say, well, my heart might be racing, my breath might be racing, I might feel like I'm tensing my muscles, protecting myself from a lion, getting ready to run away. My stomach might not feel so good. My skin might be clammy. And I say, yeah, that's the activation of your stress response. So through cortisol and adrenaline, when there's some sort of stress in your environment, you get a release because your fight, flight, or freeze response is happening, your sympathetic nervous system is activated, and all these different things might happen, right? So the blood is running to your limbs in order to help you either fight the lion or run away from the lion, or sometimes by mistake freeze from the lion, but it's not there to support your digestion. And so it's not time to eat your lunch, and you're not getting a lot of blood flow to that part of the body because you're getting prepared to negotiate the threat in whichever way you deem is the right way. And so what does this have to do with our pain system? As I say, our pain system and our stress system are very linked. Number one, what we have to understand for this slide is that we have a manifestation of our emotions, right? The emotion we said was being fearful or worried, excited, or curious, but that resulted in some sort of physical presentation in our body. Our heart was racing, our muscles were tensing, our stomach didn't feel so good. And we know that on a high level, right? So when I am embarrassed, my cheeks turn red, or right before a talk, my heart racing. But to really understand how connected it is through the release of hormones and through exactly what we experience related to our stress response is really key to note. So lesson number one is that we really see a connection between our mind, our emotions, and our body and our physical sensation. Number two is that that's going to be different for everyone. So for lots of us, it might be a lion that triggers this sympathetic response. But for some of us, it might be a public speech, having to do a test at school, having to go into public or do some sort of social outing. It's going to differ for everyone. And that's what's going to create that response in their body. Is going to be different for one person than for another. And number three is that this system is highly linked to our pain protective system. This is a protective system, and so is our pain protective system. Pain is a stress. So when people have high pain, they might get a release of cortisol and adrenaline. They might have that increased stress response in their body. They might tense their muscles in protective mode or get some of those other physical sensations in their body. But conversely, our stress system, when it's activated, actually might trigger our pain system because it creates a situation where our brain is in more protective mode, our muscles are tensing. And so if you get tense muscles on top of discomfort, if you have a brain that's more likely to see things in terms of danger, you're more likely to get danger messages in the form of pain. So they're really linked quite significantly in our brain and our body, our stress system and our pain system. And what that tells us is sometimes in order to treat the pain system, we actually have to get at the stress system, which is highly linked. So up until now, it kind of made sense, right? We explained that pain is a danger message from the brain. It made sense that it would be there to protect us, but that was really in the sense when it was an acute important injury, when there was something like an ankle break or protecting from our hand getting burned. But we know that chronic pain is actually quite similar. It's different in the sense that it lasts longer than 3 months and it's over and above what we expect for some sort of injury. However, it's not as good at indicating of what's going on in the body. So for example, it's still a sign of danger from the brain, and it's still highly linked to our stress system, but it's no longer giving us really good information about what's going on in the body in terms of a warning signal as acute pain. And we know from science that it's helpful to explain pain in terms of metaphors. So here's a couple of metaphors that I have that I often use. We see our pain protective system when it works well. It's similar to a fire alarm. A fire alarm is only activated and sending messages of danger when there's some sort of fire in the building. That's when it's helpful. That's when it gives us a good message. There's a fire in the building, everyone gets to safety, it's done its job. But I ask the teens and kids, let's say there's a fire alarm that is sounding because there's a fire, and the firefighters come and they start putting out the fire. So the fire's getting smaller and smaller and smaller. It's smoke, it's embers, it's gone. Is the fire alarm getting quieter and quieter in relation to the fire getting smaller? Or is it still going at full blast? And inevitably say, well, it goes full blast until someone turns it off. That's what our pain protective system. When our body and our brain are in protective mode, those danger messages are being sent at high volume, whether there's an underlying fire or not. So a lot of teens and kids might come and they're not sure when their pain started. Some of it might have started when there was some sort of injury or illness, and sometimes it starts and we're not even sure the pinpoint of where it is. But what we do know is that when pain's been around for a long time, it's that pain protective system that keeps on sending those danger messages, whether the underlying thing is important or not, whether the fire is present or gone. Another example of a metaphor might be a car alarm. A car alarm is only meant to be activated when someone tries to break into a car. So that's when it's going to give us a good message about something dangerous going on. But I've seen car alarms go off in the parking lot when there's a gust of wind or a leaf. And so it's kind of that overprotective car alarm that's being activated or triggered related to something that shouldn't be activating it. So for example, a teen or a kid who has pain or discomfort or those danger messages coming out, even to light touch of their hand or to a gentle movement, that alarm of saying danger, danger is being activated when we don't want it to be. And so we get into a bit of a cycle. Someone might have pain. And like I said, sometimes we know the reason that started it, sometimes we don't. But whatever it is, every time they move or use that part of the body, it doesn't feel good. Their brain and body are in protective mode. And so use or movement or touch of that part of the body actually causes more discomfort. And so the natural response is to protect, to stop doing the things that are aggravating, stop using, moving, touching that part of the body. But when that happens, there's things that happen. So if you avoid touching a certain area, if you bubble wrap it and kind of keep it and avoid it, actually the nerves become more sensitive. If you don't move or use a certain part of the body, it can become weak, inflexible, deconditioned. It can create our brain to kind of say, oh, this is a dangerous area. We don't use this part. And it can create a situation where the brain is actually seeing that part with more protection and more likely to send down danger messages to that part because it's seen as an area that's off limits. And then it starts impacting function. And for our teens, function means being able to have good sleep, go to school, see their friends, and do appropriate physical activity. And when those things start being impacted, that can actually increase pain. So when kids and teens are not getting sleeping well, we know their pain increases. When they're not having regular routines, when they're not doing good physical activity, we know this pain increases. And there we go, the cycle continues. And look at all the things that can contribute. Anything that's going to cause our stress response, like being fearful or anxious or worried, that's going to increase our muscle tension. That's going to increase the brain to be more likely to send down danger messages because it's in protective mode. Things that stop us from going to school or low mood or have poor sleep, that's going to create that situation of the cycle continuously going. And another metaphor is just like I have this green grassy field by my house, and over time, cyclists and dog walkers, kids and teens have carved out this pathway. So it's almost like all the information coming from that part of the body is processed as danger, and all the messages down from the brain to that part of the body are in the form of pain. And it's this loop that keeps on going. Like with most cycles, we have to kind of get in there somewhere. And with acute pain, we can generally say if there's an important injury, when the injury heals, the pain goes away, or at least starts going away. But with chronic pain, persistent pain, there's so many different factors that are creating a situation where the cycle keeps on going that actually to say to wait for the pain to go away before we start doing those things is really, really challenging. Remember that pain system is not giving us good information. So we start elsewhere on the cycle. We don't start with decreasing pain per se, but we look at things that help decrease the protectiveness of the brain and body, downtrain the nervous system, quiet some of the things that are creating the brain and body to be in protective mode. We start slowly exposing our body to graded movement, to graded touch, to graded use. We start slowly improving our strength, endurance, tolerance to touch, range of motion, our mood. And then we started really looking at improving functional participation. So getting back to routines, good sleep, good school attendance, socialization, and good physical activity. And then we can start having a reduction of the impact of pain on our lives. And that's the cycle that we're trying to get into. And look at the things that can contribute: decreasing the stress system, having good sleep hygiene, things like positive mental attitude. All of those things can create less protectiveness of the body and the brain, help downtrain the nervous system, and allow us to participate in function. And so we use this multimodal approach. And really, that's what we're trying to really hone in on. Why are we throwing psychology or occupational therapy, physical therapies, and pharmacology at this teen who has pain? And if we can understand, or we can really give a good explanation about what pain is, we can see, well, pain impacts the mind and the body. Pain is related to our stress system. So it makes sense that we want to look at the psychological strategies to help decrease the stress system, to help decrease the fear and the protectiveness and other type of things that might be contributing to protective response like anxiety and depression. Of course, we want to look at the physical because we want our body to be well conditioned. We want ourselves to be flexible, have good strength, endurance. We want our brain to be less protective and not avoid using or moving. We want to desensitize sensitive nerves. And sometimes there's medication as well. And when medication is there, it's to help support the participation in some sort of mind, body, and movement strategy. And we think of it almost like three legs of the stool. The when pain's been around for a long time, that it really requires this multimodal approach to reduce it and it reduce its impact. So we look at reversing the pain cycle we look at using this multimodal approach of the 3 Ps, the physical, psychological, and pharmacological strategies. And we're hopeful that with this educational strategy, we're able to really understand what pain is, help reframe it as a very protective pain response for pain nervous system. We really look at reversing the pain cycle through this multimodal approach, through use of a pain education strategy to understand and help reframe what pain is. We want to make sure that our teens and kids understand the importance of the physical, psychological, and sometimes pharmacological strategies, and really try to return our teens and kids to function using these strategies. Just an article that I stuck in on the back with some language that might kind of facilitate the danger messages in the brain versus language that will not. So that's a good one if you want to use some language that's helpful and avoid kind of the jargon that increases the pain response in the brain. And another article that I've attached that uses a lot of different analogies and metaphors. So similar to fire alarm analogy, we have a hardware and software analogy and lots of different analogies to help reframe what pain is and explain what it is, and the effort to allow our teens and kids to participate in a multimodal functional rehab approach to addressing pain. And there are some resources at the back.